So Bob, what do the CVD-REAL study results tell us about reducing cardiovascular events outside a high-risk population with diabetes?
So it's a good, it's the beginning of what I think we'll see a lot more of, and that's using big data to try to answer some of these questions. So, as we heard, we don't have a lot of answers. There's a lot of hypotheses. Is it class effect? What's the effect on congestive heart failure? We have some data, but not all the questions answered. And there are a number of studies that are ongoing, which will take some will get sooner, but some will still take several years. So what do we do in the meantime? And so this was a retrospective analysis looking at a large data set to be able to identify, one, is there a signal for a reduction of congestive heart failure across the class? And it seemed as if there was. Now, again, the challenge with a retrospective analysis is you're not randomizing people to therapy. There's a whole host of potential confounders. But for a lot of the questions that we brought up here today, we may need to depend on that kind of analysis to at least decide what to do with our patients that we see next week. So I think there's value in them, but we can't put too much weight on them.
And are those studies at least attempting to control for some of those confounders, even if not in a randomized fashion?
Yes, right. I think the well-designed studies, really do try to balance things as much as possible. Again, within the realm of the things that we know. And, prior to EMPA-REG, no one would have thought of matching based on SGLT2 treatment. So there will always be those surprises. But yes, the goal is certainly the larger the data set, the more balancing one can do.
Now, the important aspect to CVD-REAL, although you should always take these observational studies with a grain of salt because of what you alluded to, which is really a channeling bias. Certain patients get channeled to certain therapies, so we need to be cautious. But it's important because it included, as far as I recall, patients not necessarily on empagliflozin. I think EMPA was actually represented with 1 or 2% of the participants or the patient population. It was mostly driven by canagliflozin and dapagliflozin.
Exactly.
And it's a multinational observational study. And they used propensity matching, which is, I'm not a statistician, but my statistical friends tell me that's kind of state-of-the-art way of doing these observational trials, that you match patients for individual characteristics so that they say it's almost as good as a clinical trial. But the effects were as prominent as an EMPA-REG outcome. There was a reduction in heart failure hospitalization, and I believe they reported all-cause mortality. I don't think they reported CVD.
Yeah, I was going to say that not only heart failure, but also mortality was decreased. So, I mean, a dilemma is, are enough variables measured so that the channeling bias can be overcome by the propensity matching algorithm? Are there certain things about that person who pushes his doctor to be on the new medicine which makes him or her have a better outcome? And, but yet this is, there are a number of questions that simply could never be addressed in a randomized controlled trial. And I'm involved now in a study of sudden death in diabetes, which quantitatively is actually a pretty big deal. But because event rates are so low, you could never enroll enough people in an RCT. So you go to these propensity matching algorithms, you get large data sets, and maybe we can address the question of whether sulfonylureas are truly bad for you, or different ones different.
But those drugs always look bad in these non-randomized observational studies. But when they're submitted to randomization in a clinical trial, they look either neutral or slightly beneficial. And now the question is whether the patients who enroll in these randomized clinical trials are somehow different than those in the real world. They get better care in terms of closer observation. And that may not occur in the real world. I think it's great when the randomized clinical trials and the observational data sets point in the same direction. But when they don't, I think it's really confusing. A big caveat comes from the DPP-4 inhibitor experience. There were several large observational, non-randomized trials, retrospective, that suggested that the DPP-4 inhibitors had a dramatic effect on cardiovascular events. Yet we now know, at least with 3 of the drugs that have been reported, sitagliptin, saxagliptin, and alogliptin, that they are wonderfully neutral. In other words, no risk, but clearly no benefit. So here you have a disconnect between those observational data. I'm not recalling whether they had propensity matching in those, but I think at least one did.
They did.
So just a caution, we should
Right.
wait for
And-
the RCTs.
And I put my foot in my mouth in print and said how wonderful they were. So, but there is a trial, Carolina, which will compare linagliptin with, I believe, glimepiride, head-to-head in a high-risk cardiovascular disease population. And so I think in 2018, we'll have an answer as to whether sulfonylureas head-to-head with DPP-4s are bad or DPP-4 is good. So let's hang on to our hats for another installment.